Whether it's psychological treatment or drug treatment, it's really all about trying to reduce the symptoms rather than understand where those symptoms might have come from. In other words, we're not getting down to the root cause. And the idea in the book is that, at least for some people with depression, the root cause may be inflammation.
Hello and welcome to our podcast Pager. I'm George Milner.
And I'm Stan Dale.
Tune in to hear us talk with some amazing people about the subjects changing medicine today. Despite the enormous health burden of depression around the world, its underlying causes and how best to treat it are poorly understood. However, recent evidence suggests that in a significant number of cases, inflammation could be a potent driver of many common diseases, including depression. This theory links the body and the mind in a new framework that could help to prevent depression and design better treatments for it. Our guest today hopes for just that. Professor Edward Bullmore heads up the Department of Psychiatry at the University of Cambridge. He is also a consultant psychiatrist at Addenbrooke's Hospital in Cambridge and the author of the best-selling book titled The Inflamed Mind, a Radical New Approach to Depression. In the first of 2 episodes, we discuss the evidence for the relationship between inflammation and depression and the causal role of inflammation before touching upon how this relationship could work on a mechanistic level. To find out more, have a listen to the second part of our discussion, where we look at how this new theory of depression could help with targeting the disease. So, Professor Bullmore, welcome. It's a pleasure to have you with me today.
It's a pleasure to be here.
Whilst depression is quite a complex and varied disorder in different people, how do we go about defining it in clinical terms?
Well, at the moment, the diagnosis is usually made by following a checklist of symptoms. There's an organisation called the American Psychiatric Association. It's published something called the Diagnostic and Statistical Manual, or DSM. And if you look up in there, major depressive disorder, there's a list of symptoms. You have to have low mood, and you have to have less capacity for pleasure than normal. So that's a symptom that we call anhedonia. So you've got low mood and anhedonia, loss of pleasure, and then some other symptoms, and they have to be of sufficient severity to cause a degree of distress or impairment. And that's it for major depressive disorder. There is one caveat, which is that if the patient has a medical disorder that could possibly explain their depressive symptoms, then by definition they can't have major depressive disorder. They would have something often called comorbid depression. But all of it is diagnosed based essentially on what people say. There are no blood tests or brain scans that contribute to the diagnosis. It's entirely clinical.
And in fact, I've got your book in my bag currently. And
very good.
It's titled, summing up, The Radical New Approach to Depression.
Yeah.
What exactly is this?
Well, so, people get a little bit anxious sometimes about the word radical in that subtitle. But the reason I used radical is radical means you're going to go to the root. And I think one of the problems we have in psychiatry generally, and certainly in current thinking and treatment about depression, is that the treatments we offer are really all efforts to alleviate symptoms. So if I go to see a GP and I say, I've got low mood, I'm enjoying life less than I used to, my sleep's a bit disturbed, my appetite's a bit disturbed, he will rightly say, it sounds to me like you've got depression. And then without thinking too hard about what could have caused that depression, he'll offer me treatment with an SSRI, a serotonin reuptake inhibitor like Prozac, or he might offer me a bit of cognitive behavioural therapy. And whether it's psychological treatment or drug treatment, it's really all about trying to reduce the symptoms rather than understand where those symptoms might have come from. In other words, we're not getting down to the root cause. And the idea in the book is that, at least for some people with depression, the root cause may be inflammation, and therefore in future we might do a better job for patients if somebody comes into the GP surgery, they've got the symptoms of depression, then the GP or the psychiatrist or the physician says, I wonder, could that be because you're inflamed? Let's do a blood test, let's see whether there's any evidence of inflammation. And in that particular case, if there was a positive blood test, well then the treatment will be targeted more on the cause rather than the symptoms. So that's why it's called radical, because it's an effort to get below symptoms and try to understand the cause of those symptoms. It's arguably also radical because, and this is a little bit more philosophical, that our current way of thinking in in Western medicine is very segregated. It's very split between problems of the mind and problems of the body. Psychiatrists look at the mind, physicians look at the body, and they tend not to talk to each other all that much. Patients very rarely see a psychiatrist and a physician together. They'll usually have to go to different hospitals or attend different clinics to get medical advice concerning mental or physical symptoms. So we've split ourselves. We tend to kind of, in inverted commas, split our patients into mind or body. That's a philosophical tradition in medicine that goes back a long way. But the ideas in the book, I think, are radical in that they kind of transgress that traditional distinction, and they point towards situations which may be commoner than we appreciate, where bodily disorders causing inflammation may directly cause mental health symptoms such as depression. In other words, body and mind are more joined up, it may be, than we typically think they are in Western medicine.
So in the studies done so far, how frequently do we see inflammation in patients with depression?
Well, remember, when we've got to think about the major depressive disorder on the one hand and the comorbid depression on the other hand. So that is depression that co-occurs with a medical illness or not. So amongst the group of patients that have major depressive disorder, no associated medical illness, the people currently say about a third of those patients may have low-grade inflammation. So you wouldn't be able to detect this clinically, just by talking to the patient or examining them. But if you run a blood test and you look at levels of inflammatory proteins in the blood, like C-reactive protein or cytokines, about a third of patients with major depressive disorder have levels of those proteins that are higher than the upper limit of the normal range. So let's say provisionally about a third of major depressive disorder. And then if you look on the other side of the sort of conventional diagnostic divide, if you look at the comorbid depression, it varies from physical disease to physical disease. But rheumatoid arthritis, for example, which is primarily an autoimmune disorder that affects the joints and other parts of the body, we know that about 25% of patients with rheumatoid arthritis have significant depressive symptoms. And if you sort of slightly broaden the scope and say, well, how many people with rheumatoid arthritis have psychological problems more generally? That could be depression, it could be fatigue, it could be this thing they call brain fog, which is just a sort of kind of mild cognitive impairment. It's a very high percentage. Some people estimate up to 80% of patients with rheumatoid arthritis would rank fatigue, loss of energy, as their main problem with the diagnosis of arthritis. So stack that all together, you're talking about 30% of major depressive disorder, and let's be conservative and say about 25% of medical inflammatory disease. That is an awful lot of people. It's not everybody, okay, so this is not a panacea approach, it's not going to cure everybody, it's not going to make the whole world happy, but in terms of the numbers of people involved, it's still a hell of a lot of people.
And looking at this group with comorbid depression, how can we determine the direction of causality here? How do we know? And perhaps that's a question that's been holding the medical profession back from recognising the link between inflammation and depression. But how do we know that actually it's not the condition that's working in the opposite direction to make people depressed, or that there's some crosstalk? How do we know what proportion of that is actually inflammation driven?
Right. Well, that's a very good question, and actually, that is probably the central question of the book. Is how do we establish that causal relationship? It's worth just stepping back a moment and saying, that the association between inflammation and depression, I don't think is in reason. I don't think that's subject to reasonable doubt. Okay, I think we all know from some of the stats I've already mentioned, and actually I would also argue from personal experience, we all know that inflammation and depression tend to go together. The question is that because inflammation is causing depression or not? There's two answers to that question, animal and human. So if you do experiments with animals, if you take a perfectly healthy rat and you make it inflamed. For example, you inject it with an antigen like LPS, lipopolysaccharide, or you inject it with inflammatory proteins like cytokines, that animal will immediately change its behavior in quite a predictable way. It'll become less physically active, it'll interact less often with other animals, and a normal rat, given the choice between a sugary drink and plain water, will generally prefer the sugary drink. We assume that's because they find sugary drinks more pleasurable. But when you've made a rat inflamed and you offer it that choice, it shows less preference for the sugary drink, which people generally interpret as indicating that that rat has anhedonia. That rat has lost the capacity for normal pleasure. So you can make animals inflamed and you see reduced mobility, reduced social interaction, reduced capacity for pleasure. It looks as if they're depressed. Personally, I find that animal literature quite persuasive. Lots of experiments have been done in great detail to elaborate the causal connection and to show that there is a sort of step-by-step sequence of events by which an injection into the bloodstream of an inflammatory protein like cytokines can cause inflammatory changes in the brain, which lead to changes in neuronal function, which cause the behavioural changes that we see. So in the animal case, I think it's pretty well worked out. But then a lot of people would say, well, depression is a disorder of, a uniquely human nature. Are you telling me that inflamed rat feels guilty about things he's done in the past? Does that inflamed rat have a sense of despair about the future? How many inflamed rats have ever acted suicidally or taken their own lives? So there are aspects of depression in humans that aren't very well modelled in animals, and some people would say that is sufficient to discount all the animal evidence and want to know, well, what's the evidence in humans? Now, when we come to look at causality in humans, obviously we can't do the kind of experiments that you can do in animals, but we can do some very interesting experiments nonetheless. So we can look at how events unfold over time. Generally, a cause precedes an effect. So if inflammation was causal, you'd expect to find examples of inflammation occurring before depression. And people have looked into that question, and there is evidence that it is the case. And you can see that on a number of different timescales. So there's a study I put in the book that was done by Golem Kandekar and Peter Jones here in this department. They looked at longitudinal data where kids had inflammation measured at the age of 8 or 9 and then were assessed for depression at the age of 18. And the kids that had increased levels of inflammatory protein at the age of 8 had increased risk of depression 9 years later. Hepatitis used to be treated by interferon, and interferon obviously is a very powerful pro-inflammatory stimulus, and it turned out that a lot of the patients, about a third again, of the patients with hepatitis treated with interferon developed depression about 6 weeks later. And the third example I'd offer is perhaps more familiar to people, is vaccination. If you go to Africa or somewhere else in the tropics, you will want to get a typhoid vaccination. And when you go and get that done, the nurse will tell you, you might want to take tomorrow off work because you're going to feel a bit off colour. And, I had that experience recently, and it's true. You have the typhoid, a day later you don't feel so great. Not clinically depressed, but definitely less energy, less mood, lower mood. So these transient depressive symptoms that you see following vaccination are consistent with the same story as the hepatitis and the longitudinal epidemiology. In every case, you've got inflammation preceding the emergence of depressive symptoms, whether that's a day later for the vaccination, a few weeks later for the interferon treatment of hepatitis, or many years later. In the epidemiological data, the same story emerges. And I think that's important. I think that's a necessary condition for inflammation to be considered causal. If you couldn't see that evidence of precedence in time, I think it would refute causality. We can see that there's evidence for precedence in time. I think that's encouraging, but not yet sufficient. We need to do more studies in humans to understand the exact causal chain with the same level of detail as we can already see it in animals.
And that's interesting, actually, the different time periods over which depression develops. We've got 6 weeks, we've got a few days, and we've got many years. Because I think the statistics show that an estimated 3/4 of mental health conditions in people are established by the age of 24. So 6 weeks is what we perhaps see as the window of time before drugs like SSRIs work or perhaps don't work, according to the literature.
Yeah.
So why is there perhaps this delay in some cases with inflammation causing depression?
Well, I think that's a very interesting question, and to be honest, I'm not sure that anybody really knows the answer to that question right now. I think one way of thinking about it is to ask yourself the question, okay, assuming that inflammation can cause depression, what causes the inflammation? And if you think back to those kids, those 9-year-olds that I mentioned, there's a distribution of inflammation at that age, and there's a group of kids with slightly higher levels of inflammation than some other kids. Now, what is it? What could possibly cause those increased levels of inflammation? And one possibility which has emerged in several studies, and I think is very interesting and intriguing, although not yet completely nailed down, is the idea that in childhood the immune system reacts to stress, to social stress. So as a child, if you're exposed to maltreatment of any sort, that could be abuse, it could be emotional deprivation, it could be poverty. All of those factors may act to increase the levels of inflammation, which is I think a very interesting idea. When I first came across it in the literature, it struck me as, first of all, a completely new idea. Never really crossed my mind that a social stress could have that sort of physical inflammatory response. But there is pretty robust evidence that it does. Again, both in animals and in humans, social stress causes these inflammatory responses. And if you think about it a little bit more open-mindedly, think, what does it mean to a child to be deprived of its parents, or to be otherwise subjected to extreme social stress? Well, historically that would have meant that child was very much less likely to survive, right? It's going to put that child at risk of infection, of all sorts of adverse physical outcomes. So maybe it's not that surprising when you think about it that the immune system should be engaged, should be activated, not just by biological threats like infection, but by social threats like stress that historically at least might have impacted on a child's chance of survival. With all that in mind, my provisional answer to your question of what explains these very long-term relationships between inflammation and depression, I would say it's possible that children are exposed to social stresses, may have an immune response, and may have a memory of that exposure that the immune system holds, in the same way that the immune system can hold a long-term memory of a biological threat like infection. Maybe the immune system holds a long-term memory of a social threat like social stress in childhood, and that stays with you, into early adulthood, and then may put that individual at greater risk of becoming depressed when they encounter subsequent stresses in later life, for example.
But going back to your example of a child in an evolutionary sense, depression and the behaviours associated with it in response to isolation from parents, that doesn't seem like a very advantageous set of responses. So what perhaps is driving this link from? I can see how inflammation might help with that and this immune response. But what about the link between inflammation and depression then?
From an evolutionary point of view?
Yes.
So, well, you're right. On the face of it, depression doesn't look at all advantageous. Okay, so if you're depressed, you are likely to die younger. You're less likely to be married. You're less likely to have children. It's not fit in the. It's not a fit state in the sort of evolutionary sense. So why could it? In what way might it have made sense for us to evolve this relationship, this coupling between inflammation and depression? here again we're into a sort of somewhat speculative theoretical space, as is generally true with a lot of evolutionary theories. But people have made the argument that going a long way back in our ancestral history, when the principal threat to survival, or one of the principal threats, would have been infection, and a lot of infection would have been caused by trauma, it could have been advantageous for infected individuals to show a set of behavioural changes that we would now recognise as depressive. So, for example, if I was a caveman and I, had a wound to my hand which became infected, it might help my survival if I withdrew from contact with the rest of the tribe, if I was perhaps spared the social duties that normally go with tribal affiliation, if I perhaps reduced my physical mobility, so I'm conserving more metabolic resource to fight infection, if I changed my pattern of eating, so again I'm saving metabolic resource from digestion to invest, if you will, in the immune response. Maybe those behavioural changes could help me, maybe the behavioural changes co-opted by my immune system could help me survive that infection. Quite a difficult theory to test experimentally, because of course we can't go back to Neolithic times and actually work out what was happening. But it does have some testable predictions, and one of those is around genetics. So if it was true that this link between inflammation and depression had been selected by evolution because it made us more likely to survive, then I would anticipate that risk genes for depression that we can identify now in the 21st century should be specialized for immune functions, perhaps particularly immune functions involved in the innate immune response to infection. And that's, I think, the way that one should probably think about these evolutionary ideas is in the context of the genetic data that we have. And in that respect, it's very interesting that it's only very recently that we've begun to know what are the specific genes that put people at greater risk of depression. This is relatively new data, it's only just become available. And I think it's too early to be sure, but certainly when you look at the genes that have been reported, I think 44 genes have been reported as significantly associated with depression. If you look at those genes, they are somewhat enriched for immune function. So the genetic risks for depression, I would say, are consistent with that evolutionary theory. Although I would also like to see more genetic evidence emerge, and I'm sure that will happen over the next few years.
Now, I think if I were to talk to somebody maybe 20 years ago about this, one of the questions they would have is, how can inflammation in the periphery, for example, in these immune responses, actually translate into neurological effects? Because the brain is typically seen in a position of immune privilege, nested behind the blood-brain barrier. So how can we see effects actually coming across?
I hope you're still not being taught that.
Luckily not entirely, no.
No. But I mean, when I was at medical school, we were taught that as a matter of fact. That the brain is immune privileged, it sits behind the blood-brain barrier, and the blood-brain barrier was in the book I call it the Berlin Wall in the brain, because that is how we were taught about it. It was rigid, it was impermeable, it kept all the sort of immune cells and inflammatory proteins in the circulation, it kept them away from the neuronal machinery. And the dogma, well, at the time we were taught this as a matter of fact, but looking back it's clearly dogma. The dogma was that impermeable blood-brain barrier was only breached if there was some sort of pathological catastrophe, if there was a tumour or there was a stroke or some other major disruption of the normal anatomy in the brain, then maybe a bit of the immune system could access the nervous system, but under normal circumstances it was supposed to be completely segregated.
I should add in this case that when we talk about neuroinflammation, we're not necessarily talking about swelling that we might see in the periphery. It's more of a molecular profile.
Right. Well, yeah. So, and I think that's a very good point, because certainly when I talk to non-medical people about inflammation, I mean, everybody knows what inflammation looks like. If you again cut your hand, it gets infected. Your hand will become red, swollen, tender. You'll lose function. You won't be able to use it. We know all that, and that's what we think inflammation looks like. But I think one really important thing for people to understand is that under the circumstances where you can see some clinical signs of inflammation, that is only the tip of an iceberg, and there is almost always a systemic inflammatory component. And as you're saying, when we're talking about neuroinflammation in relation to depression, we're talking about something quite subtle. We're not talking about an abscess or a red and swollen painful brain. We're talking about a brain that is seeing higher levels of concentration of inflammatory proteins, a brain which may contain a lot of activated immune cells, microscopically visible but not obvious just by looking at the brain. Not obvious if you did a sort of brain scan with MRI, you wouldn't know whether one brain was slightly inflamed or not. It's a molecular, cellular change in the bias of the immune system towards inflammation is what we're talking about. So relatively subtle, but nevertheless it can have profound effects on neuronal function. Again, we know this mostly from animals. If there is increased amount of inflammatory protein in the brain, nerve cells generally don't like that. It generally makes them quicker to die, less inclined to regenerate. It changes synaptic function. It changes neurotransmitter metabolism. The inflammatory state of the brain has a lot of effects on neuronal function. We know that's pretty clear.
On the topic of perhaps more subtle inflammation, we also see certainly low-grade inflammation in a number of other conditions, including obesity. Pregnancy has a lot of inflammatory events surrounding it. Has there been any research linking this low-grade, perhaps subclinical inflammation in the periphery, not necessarily like rheumatoid arthritis, for example, and subsequent depression?
Well, yes. I mean, obesity particularly is a very interesting area, because we know that obesity and depression go together. So if you're obese, you're more likely to be depressed. If you're depressed, you're more likely to be obese. We've known that for a long time. Question, as always, is why? What's the causal relationship that explains that association? And one possibility is that it's to do with inflammation, that inflammation is the causal link between obesity and depression. And how could that work? Well, when you put on weight, when you increase your mass of adipose tissue, again, when I was at medical school, we were taught that really all that meant was that you just sort of built up your depot of energy stores. Adipose tissue is really just sort of fat, and nothing much more than fat. But we now realize that actually adipose tissue contains a lot of immune cells. It contains a lot of macrophages in particular. And it's very clear that basically as body weight goes up, as BMI increases, you can see a very robust correlation with levels of inflammation in the blood. I mean, that is, solid. So obesity is definitely a pro-inflammatory state. So I think a plausible hypothesis is that people become obese, that makes them more inflamed. The inflammation in the body signals across this blood-brain barrier that is much more permeable than we were taught at medical school, and it triggers inflammatory change in the brain, ultimately causing changes in neuronal function and behavior. And that sequence of events is how obesity and depression might be related to each other.
And could we see the circle perhaps extending further, where actually depression can lead to further obesity due to changes in lifestyle, which can lead to further inflammation, which can lead to further depression, sending the system spiraling out of control?
Yes, I think the first question is the sort of relatively simple sort of causal arrow between inflammation and depression, and then you've got another causal arrow, which is maybe obesity causing inflammation, causing depression. But as you say, there's nothing to stop that logic becoming circular. And you could say the same with stress. Stress causes inflammation, causes depression. Having become depressed, you are more likely to be exposed to social stress. You're more likely to lose employment. You're more likely perhaps to have relationship difficulties. That's going to cause stress, could compound the inflammation. So this concept of a vicious cycle is, I think, quite plausible. Sometimes people worry about that, as if that was a sort of a barrier to treatment, but I don't see it as such. I think, if you can understand the causal relationships, whether they're just sort of simple linear cause and effect relationships between a few things, or whether it's a more circular relationship, as long as you understand that, you have opportunities to interrupt it, and therefore you have opportunities to treat symptoms by treating the cause.
So we've been talking so far about correlation between inflammation and depression and obesity, and we've had some evidence for causation by actually the timing of it, for example, and experimental induction of inflammation.
Yeah.
But from a mechanistic point of view, do we have any understanding of exactly how inflammation can actually lead, and how these cytokines and proteins going into the brain, for example, can actually directly lead to depressive symptoms?
Well, I think we've got some pieces of evidence. And I suppose it helps to think about the brain at least two levels of organisation. So there's the sort of microscopic level of nerve cells and synapses and neurotransmitters, and then there's a higher level of large-scale brain networks. So that is multiple areas of the cortex and maybe some subcortical structures being linked together to serve some functional purpose. And we know from a lot of imaging studies that have been done that mood and mood disorders tend to be associated with dysfunction or disconnection between brain regions that are normally connected to form something we call the emotional brain network. It involves the cingulate cortex, it involves the amygdala, involves a number of other brain regions. These areas of the brain are connected to each other. And that's where mood comes from, and that's where mood disorders comes from. So is there any evidence that peripheral inflammation can change the organisation of those networks in the brain? And from imaging studies, we've seen in recent years surprisingly consistent evidence come through that is true. So if you do, and we've done this very recently here in Cambridge, if you do a study where you measure the functional connectivity of emotional brain circuits in depressed people who have high and low levels of inflammatory protein in circulation, you can see that the depressed people with high levels of inflammation have more disconnectivity of this this large scale brain network. So I think that's one important piece of evidence. And then at a microscopic level, at the neuronal level, much more difficult to see that in humans. I mean, how are we going to get microscopic information about the brain in people with depression? We can't do a brain biopsy. None of the imaging techniques we have that level of resolution. So we're much more dependent there on the animal models, and in the animal models, as I've already briefly said, there's pretty clear evidence that neurons that are exposed to inflammation generally don't like it, and one change that you can see this, and it's been reported by other people, we've also replicated it. If you expose neurons to inflammation, you change expression of genes that are important for controlling the metabolism of tryptophan and of serotonin. So you can make a neuron shift away from serotonin towards other more toxic metabolites, and that's one example of a biochemical mechanism that could link inflammation to changes in neuronal function, in this case reduced serotonin release into the synapse, that might be relevant to the emergence of depressive symptoms.
So with this in mind, with the fact that inflammatory markers can perhaps, or inflammatory proteins can perhaps lead to maybe excitotoxicity, and as you mentioned earlier, changes in plasticity and reorganisation of these networks, are the functional changes that we see in the brain reversible?
Yes, is the short answer. I
Reverse
think
inflammation, sorry.
Yes, I think if you reverse inflammation, I think there probably is quite a rapid. I think there is an opportunity for quite rapid restoration of normal function. I think that is, by the way, consistent with the evolutionary ideas that we were discussing earlier, that this is, the link between inflammation and depression is a sort of behavioural change to adapt to a biological or social threat. If that threat's removed or the inflammation's removed, it's to be expected, I think, that normal function would come back quite quickly. That is different, by the way, to the situation in, for example, Alzheimer's disease, which is another area of neuropsychiatry where there's a lot of interest growing about inflammation. And in Alzheimer's, the brain is structurally abnormal. There are plaques, there are tangles, there are these sort of abnormal proteins deposited in the brain, and the current theory is that those abnormal proteins may stimulate an inflammatory response which damages neurons, and that contributes to the onset of dementia. But in the dementia case, if you treat the inflammation, you're not, you may stop the progression of dementia, but you're not necessarily going to flip the brain back to normal because you've still got these, abnormal proteins, for example, deposited everywhere. Whereas in depression, I think it's more likely that the brain is structurally normal, it's just functionally biased in a different direction by exposure to inflammation. If you can get rid of that inflammatory stimulus, you may restore the normal functional performance of the brain. So it could be quite a rapid response.
Thank you for listening to the Pager podcast. If you've enjoyed it, then head to Spotify or iTunes to hear more.
As ever, we'd love to hear what you think. Do leave us a review on Apple Podcasts if you have a moment, and you can also reach us via our website and our social media pages.